thank you so much for having us here today. We're really excited to be here with you. Just as a point of personal privilege, well, we were the first union to endorse Andrew Gillum. Long before any other unions, because Andrew Gillum stood for Medicare for all. And he stood for higher standards in our state, for nurses, for patients, and for our community at large. So before I turn it over to Eve, I want to talk a little bit about why our union cares so much about Medicare for all. Medicare for all, for us, is just as important as any of our collective bargaining battles, as organizing a new hospital. This is a key part of our union's program. And we believe that we can't have a union in the hospital if the world is crumbling around us. And so nurses have a duty to advocate for the patients, and we take that duty much further to advocate for the prospective patients in the community, because we're all going to be patients at some point in our lives. So we absolutely believe that we need to have a better system in this country, and that is Medicare for all. HR 1384 was introduced about 10 days ago now with 107 co-sponsors. And when HR 676, the previous Medicare for all bill, was introduced a few years back, it only had 60 some co-sponsors. So I feel like now is really the moment. And we know that 71% of Democrats support Medicare for all. Nearly 40% of Republicans support Medicare for all. Now, they vote against their interests, fancy that. And the majority of Americans, about 60% of Americans now support Medicare for all. So the public is with us. Unfortunately, some of the Democratic leadership is not there yet, even though the vast majority of the American public and the party support Medicare for all. So we have to constantly make calls to our congresspeople, constantly be visiting their offices. So I'm hoping after this presentation that everybody can make a phone call to their congressperson, even if they're Republican, because the Republicans need to hear that people in their district support Medicare for all. If we can now go through the PowerPoint. Okay, great. So NNU and its affiliates have been working for decades to bring life to a more humane healthcare system based on patient need, not on private pain and profit. So in every single step of our healthcare system right now, we have hospital systems siphoning off profits, we have big pharma siphoning off profits, we have insurance companies siphoning off profits. It's like every step, durable medical goods, profit. So we believe healthcare is a fundamental human right, and all nurses are on the front lines of our country's healthcare crisis. Click and click. I forgot my clicker today. Because nurses work directly with human beings when they're at their most vulnerable, least dignified states, they have a special vantage point to how to fix our broken healthcare system. And every day at work, nurses like Eve and her coworkers bear witness to how our for-profit healthcare systems harms patients. And in Florida, the majority of our hospitals are for-profit hospitals. They are traded on Wall Street like McDonald's. So even when their patients have insurance, nurses bear direct witness to the heart-wrenching decisions their patients and their patients' family members are forced to make because they cannot afford the care they need. How many people know somebody that's gone bankrupt because of healthcare needs? So quite a few of you here in the audience. It is the number one reason for bankruptcies in this country. So we can go on then to the objectives. Excellent. Where we're supposed to be. Okay. So throughout this presentation, we'll provide a clear and concise definition of single payer and make a case for why it is the only real solution for our current healthcare crisis. Any other solutions that folks are talking about right now continue the profit motivation in our healthcare system. We'll review the history of the relationship among unions, the working class, healthcare reform, and healthcare justice. And we're going to identify the core historical lessons of this relationship and apply it meaningfully to our current efforts to build a broad-based movement for Medicare for all in our country and against the privatization of healthcare internationally. Next slide. Okay. And there are three bullets here. My sense is that everyone here has a basic understanding of what single payer is. Many of you are the beneficiaries of the single payer system, I might guess. Many of you are probably in Medicare. Are people happy with Medicare here? I usually ask that. I usually ask the question, are you happy with your health insurance? And the only people that raise their hand are the people that are on Medicare. So what we want to do, I didn't ask that because I figured many people were. So what we want to do is expand the current Medicare system and improve it. And improve the risk pool to include young folks too that maybe not be users as much in their life, which will make our system more solid, really. So first and foremost, in a single payer system, everybody's in and nobody's out. It's a universal system of healthcare based on the idea that healthcare is a human right and not a commodity to be bought and sold for profit. I mean, that's what it is right now. These for-profit hospitals, the insurance companies, they are selling a product and they're not caring for patients. Under a single payer system, care would be financed through progressive taxation, not premiums and other cost sharing like co-pays and deductibles, because people, even with insurance, can't afford to go to the doctor. Some examples of tax proposals that have been floated as options for various proposed single-payer legislation across the country are gross receipts taxes for businesses making more than $2 million in revenue each year, or payroll taxes paid 2/3 by the employer and 1/3 by the employee. That would still be cheaper than our current system. Different proposals are on the table concerning who would oversee the trust fund, to which the government body or branch of government, this trust fund advisory committee would be accountable. And these issues are way too complex to get into during this presentation. What we are calling for looks a lot like our current Medicare system, but extend it to everybody. We can go to the next slide. I got like 5-point font here. So what do we mean by improved Medicare for all? So there are 6 bullets here. So affordability. So this would give the working class true power. So probably many of your children, many of your family members and friends have a job maybe that they aren't that happy with, but they remain in that job because of the healthcare benefits. Because if they quit that job, they don't have healthcare benefits anymore, and that's usually when people get sick, is when they don't have healthcare benefits. So this keeps people down. This keeps people from actually taking some risks in their lives, from maybe doing something a little more creative. So this is one of the ways that the corporate capitalist class, really sort of holds workers down, is by keeping them in positions where they are, sort of held in line. It also prevents, a lot of people from taking a leap with their coworkers to take some collective action like striking because they're afraid that they might lose their health benefits. Another thing that we talk about when we mean improved benefit for all are uniform benefits. Right now we have the best healthcare system that you can afford. So if you are extremely wealthy, you probably have great healthcare. But if you're not extremely wealthy, you don't get the same benefits. True prevention, that folks can actually see a doctor before they need to cut off their leg. It was like just a rash one day, but then you got to cut off your leg. That's crazy. Free choice of physicians and other providers. No insurance industry interference, because remember, how does the insurance industry make money? Denials, right? They make it through denials. By not providing care. How many people have had their care denied here at some point in their lives through an insurance company? Okay, so maybe about a quarter of our audience here. Reduction of administrative waste, and in a later slide we'll see the executive salaries, and it is obscene. And then common sense budgeting. Why do we have the most expensive pharmaceuticals in the world? Why are procedures, triple the price of what they are in other industrialized countries? I mean, it's real nonsense. So if we can go to the next slide. There we go. So we have a multi-payer system, a profit-based system. And so our system is very complicated. There are multiple payers for healthcare. In addition to the profits it generates, the fragmented and multi-layered structure of the system adds to the cost of healthcare by requiring large administrative staffs to cope with the many policies, exclusions, denials, deductibles, co-pays, and out-of-network charges. So all of the hospitals, all of the insurance companies have back offices with lots of people working in them, to administer this kind of crazy system. In a single payer system, all of these multiple payers would be made into one, the government. We have, hospitals, we've got, doctors, the prescription drug companies, administration, how crazy is it that our hospitals, advertise? They have that, on their sign that, it's like 10 minutes to get into the emergency room, usually a lie. Because nobody wanted to go if they said an hour wait or 2 hour wait, which truly is. The advertising in our healthcare system is also crazy, So if we can go to the next slide. This is just a really quick comparison graphic to show you that 25% of our national healthcare expenditures goes towards administration. 25%, not providing care, to administration. This figure is considerably lower in comparable countries with single-payer systems. So you see Canada, 12% of the cost of healthcare is spent on administration. So much, much lower. Go to the next slide. So the United States spends nearly twice as much on healthcare as the OECD average and has the worst healthcare outcomes of any OECD country. So we spend the most for the worst. And so we'll take a quick look at these outcomes in a moment. The OECD is basically an organization of the wealthy industrialized countries of the world. And as a nation, we currently spend 18% of our GDP on healthcare. And by 2026, 20% of our GDP will go towards the cost of healthcare. I think everyone, no matter their political ideology, agrees that this system needs dire reforms. But obviously there are different understandings of how the healthcare reform should look. I'm going to criticize the Democratic establishment a little bit here. They have taken an incrementalist approach to healthcare reform. The Affordable Care Act was a good step. Many people are covered now that weren't covered previously. Children that are covered, people's children that are just out of college are covered. Until the age of 26. But it was a huge bailout of the insurance industry. The mandate required people to buy private, for-profit insurance. So there are some good things, and who was the first? Who really was the founder of the Affordable Care Act type system? It was Mitt Romney in Massachusetts. Even though with the ACA more people are insured, a much larger portion of those individuals are underinsured than ever before because they may have insurance but they can't afford to use it. And so 32.9% of Americans are underinsured currently. And just because we have healthcare doesn't mean that we're getting the healthcare we need. So if we can go to the next slide. So hospital price gouging. So the average cost to charge ratio. So hospitals in Florida have some of the highest cost to charge ratios in the country. And in fact, some hospitals in Florida charge 1,000 times more than what it actually costs. So you've all heard of like the $100 Tylenol that you could buy at CVS for, a few dollars. Some of the hospitals, even close to you all, charge 1,000 times what it costs them to provide the care. Who's getting that money? It's not the providers in the hospital, it's not the nurses, it's not the people that sweep the floor, it's not the secretaries in the hospital on the units, it's not the nurses' assistants, it's the executives. And the cost to charge ratio has risen rapidly and continues to rise under the ACA. So if we can go to the next slide. So right now we have these accountable care organizations. You hear your hospitals forming accountable care organizations. Those are basically to limit the amount of care that's provided. And if we can keep clicking down a little bit until we hit, and one more, and then one more. So you hear about bundle payments, value-based purchasing, capitation. I make a funny joke when you see the executive salaries. You're going to want to probably engage in some decapitation. Under the accountable care organizations, providers profit from providing the least amount of care possible. So our system is based upon providing the least amount of care. You often hear like, oh my gosh, if we have Medicare for all, we're going to have to ration care. It's already rationed. We already have death panels. Who are they? They're the insurance companies. We heard Sarah Palin and their death panels. And so now we're going to hear the story of Drew Calver in Austin, Texas. And maybe this will hit close to home for some of you all. He's a teacher with health, yes, this one. He's a teacher in Austin, Texas, who has health insurance.
They never worked with us or offered to work with us until August. So until then, all we would get would be phone calls saying, You owe us $108,000. Would you like to pay it in one payment or two payments?
They say this summer they were told they'd have to foot the whole bill, and collectors began calling.
I need to focus on staying healthy and prevent another heart attack. This is doing the exact opposite.
St. David says they did everything right in this situation. Calver's insurance just has a narrow network, and he got a large chunk of the bill because their hospital was not in network. St. David's also estimates that if Calver applies for financial assistance, his bill could be reduced to less than $800. But the Calvers say it's the first they've heard of that number.
I think it's important that people realize that even with insurance, doesn't mean you're covered.
Alyssa Gord, KXAN News.
Aetna, who covers Calver's health care plan, explained they only administer claims for AISD who is self-insured. AISD tells us that they provide plans to more than 11,000 employees, but they say that the ability to offer low-cost coverage and a variety of options is becoming increasingly difficult as healthcare costs rise. And if you get a surprise medical bill, it's likely because your doctor or provider wasn't in your health plan's network. According to the Texas Medical Association, insurance companies save money by severely limiting which doctors and hospitals they include in their networks. They call them narrow networks. Insurers are using them more and more, especially in Texas. The TMA is calling for more transparency in this area, saying insurance plans need to have more hospitals, doctors, and lab services in network. That way, patients have less of a chance of stumbling into an out-of-network care situation.
All right, so can you imagine if you're having a heart attack, are you going to say, take me to the in-network hospital or take me to the closest hospital? I mean, stumbling into an out-of-network situation is when you have an emergency, that's bound to happen. So if we spend the most in the world, should we have the best healthcare outcomes? I would think so. No, but we have the costliest healthcare but the worst outcomes. And the Commonwealth Fund recently put the United States dead last among wealthy nations when it comes to things like access to healthcare, the equity of our healthcare system, the quality of care for the general public, and average health. And the question is, where do all the healthcare dollars go? How much time do you have?
You've got lots.
10 minutes? I have lots? I'm good? Okay. Can you go next? Because I can talk about this all day. But I don't want to monopolize the meeting. Actually, I do want to say one thing. So the video in the Austin school district, at several levels of government here, we provide benefits to government employees. So we provide benefits to teachers and school systems. We provide to county employees, we provide health care, and it's usually the biggest line item in the budget is to provide benefits for the teachers and the county and city workers. A single payer system would benefit our educational system as well, because the school districts would not be spending all that money on health benefits anymore. They could actually hire more teachers. And in Florida alone, we could hire thousands more teachers if we had a single payer system. So the ripple effect for our economy, our education system is tremendous. So many school districts and even counties and cities in Republican areas should support a single payer bill because it would save their money, right? They're all about cutting the budget, although their the deficit climbs under their control. So hospital aggregate profits. So this is just a quick graph to show you that in the last 2 decades, hospital profits have amounted to $900 billion. And this is not adjusted for inflation. If we attempted to adjust for inflation, hospital profits over the past 2 decades would be $1.9 trillion. Even those hospitals that are, quote, not-for-profit, reap massive profits. And in fact, we've heard stories now at several big not-for-profit hospitals that if wealthy donors come into the hospital, there's a flag in their chart, so they get the VIP treatment, so that when the development folks or the donor fund people come in, they actually talk to them when they're in the hospital about donating to the hospital, which is really kind of sick. So we can go to the next slide. So these are the health insurance company CEOs' total direct compensation in 2016. So this is where your healthcare dollars are going. So just to point out a few of them, Aetna, Mark Bertolini, who was was the CEO of Aetna at the time. I'm not sure if he still is. He was making $41.7 million in 2016. How was he doing that? By not providing care. So that's my insurance provider. So we have Centene, $32.2 million. United Healthcare, $31.3 million. Cigna, $21.9 million. So this is where our money is going. And in 2016, the median earnings of full-time wage and salary workers was $43,264. So that's actually in line with what the registered nurses make by providing care. These guys make it by not providing care. So we can go to the next slide. So this is the total executive compensation. This is the combined income of the top executives at the most profitable healthcare systems in the country. So let's look at a few of them here. United Healthcare pays its top executives as a group $319 million. What could we do with $319 million? Provide care. Aetna, $252 million. Anthem, Blue Cross and Blue Shield, $224 million. So the biggest insurance companies from 2011 to 2016 spend close to $2 billion in executive compensation. It's really shameful. So we can go to the next slide. So socialized suffering. American workers bear the brunt of healthcare spending. Through higher deductibles and co-pays, or being outright denied care, we're paying the salaries of for-profit healthcare systems 1%. Employers are increasingly shifting the costs of healthcare onto their employees. And as union members, this cost sharing is oftentimes our biggest fight at the bargaining table. So the number one reason for strikes in this country is healthcare. And so here we see how workers' contribution to their healthcare premiums are increasing at a rate that outstrips earnings and inflation. Not only will our contributions rise, but our employers' contributions will as well, meaning that there will be less money available for bargaining on other significant issues like wages. And a study by the Kaiser Family Foundation that came out just a couple of weeks ago says that employees and workers together are now spending close to $20,000 a year for family health insurance. I mean, can you imagine if you don't have an employer contribution? You don't have care. So this rate of increase is twice as fast as the increase in workers' wage and 3 times as fast as inflation. And since 2008, workers' contribution to the average family premium has increased by 65%. Wages have not gone up by 65% though. Unions have long been concerned with the cost of illness for workers and the cost of healthcare for strapped working families. And I want to shift gears slightly to take a look at the history of the relationship among unions, the workers they represent, and healthcare reform to see why we are where we are today and how we can chart a different course for the future. So, next slide. Early 20th century workers built participatory democracy through healthcare. So in their own way, unions have been fighting for Medicare for all as early as the start of the 20th century, when the Western Miners Federation established a worker-run hospital system. This hospital system is still around today in Kentucky, and we actually represent the nurses there. The International Ladies Garment Workers Union soon followed suit in 1913 by establishing a union health center in New York City to treat their members who had a high incidence of tuberculosis and other health problems. And this clinic was created and staffed by those who would be using healthcare themselves, not by physicians or employers. And as the union members who ran the center cared for their ill sisters, they quickly saw the need for more universal protections. And so Pauline Newman was a garment worker who ran the Union Health Center for 5 decades. And the quote that appears on the screen demonstrates a core lesson she learned from her work with the union, with the center. Union-run healthcare threw into sharp relief the vastly greater needs of the unorganized who couldn't get the healthcare that they needed. So we see that in our own facilities. Obviously, the nurses have health insurance for the most part, but the people that are coming in the hospital and the community do not. We can go to the next one. How am I doing on time?
10 minutes.
10 minutes? Oh, we're good. So, research and lobbying, not winning strategies for labor. So I have always believed that we make change when we get through the street, when we get out into the streets. It's not, change doesn't necessarily happen, by lobbying. Although we do. What's that?
You are recommending socialism.
No, I threw you one. I already
So, what we're recommending is social democracy and participatory democracy. So early in the 20th century, industrial America faced the problem of sickness. When working people missed work owing to ill health. They also lost their wages, and so this loss of income, even more than the cost of medical care, made sickness a major cause of poverty. So most people in the world don't have paid sick time either, right? So if you miss work, you don't get paid. So in 1915, progressive reformers, led by the American Association for Labor Legislation, proposed a system of compulsory health insurance to protect workers against both wage loss and medical costs during sickness. So what I will say about participatory democracy, when people get in the streets, we saw it with the West Virginia teachers when they got into the streets and fought for their students. We saw change was made then, right? And I think everybody probably here supported the West Virginia teachers. Additionally, and sometimes it takes us getting to the street to be able to move things like Medicare. Because if you remember back to the time when Medicare was brought into reality, that was because people were on the streets first, before Lyndon Johnson actually signed the act. Labor management partnerships. So by the mid-20th century, it became for unions a trade-off between healthcare and wages. And so the UAW actually entered into agreements that would they give up the right to strike for the right to healthcare benefits. And I do believe that this was a mistake because it led many of the union members to focus inward rather than outward on the greater community. I can go to the next one. I'll skip a little bit. If we go to the next slide. Okay. So unions fight to win Medicare. So unions were on the forefront of fighting for Medicare, obviously. And so in August of 1964, 14,000 retirees arrived by the busload in Atlantic City to march 10 blocks to the Democratic National Convention to demand Medicare. And what happened in 1965? We got Medicare. Thank God for that. And I will say, so units at the Truman Library in Independence, Missouri, because Harry Truman actually wanted to, he was the first one to receive a Medicare card from Lyndon B. Johnson. He and his wife, Bess Truman, actually were the first ones to receive the Medicare card. And if you go to the Truman Library in Independence, Missouri, it actually says that Harry Truman's major regret was not getting a single payer system in his time in office. I think we can hardly say that Harry Truman was a socialist. So labor in the fight for single payer. When union density was at its height, unions were successfully winning healthcare benefits for their members. And also that made us focus more inwardly rather than on the outward community. And I do believe that in some ways our capitulation to the Democratic establishment in some ways and focusing on relationships rather than moving Democratic policymakers have actually precluded our ability to build a movement for single payer. Although we're seeing it now. I mean, you see it on the news all the time. Folks are supporting single payer. And there's been a tradition of incrementalism in U.S. health reform, which has been an impediment to large-scale reform. So if we can actually skip past the next slide so that I am mindful of time. We already talked about how this builds the industrial power of working people by having the freedom to move around to jobs. We can move on. Okay, great. So even libertarians, not socialists, libertarians, admit that Medicare for all will save the United States significant money. So there was a recent study by this Mercatus Institute, Mercatus Center, that says the United States could insure 30 million more Americans and eliminate out-of-pocket healthcare expenses while saving $2 trillion over a 10-year period in the process. This was like the big oops when they did their study, was actually that they found that we'd save money. So this is the other side. I think our struggle for Medicare for All is akin to our struggle for democracy itself. And substantially more than half of all Americans support Medicare for all. Ergo, it would create a true democracy, which, for us. So I want to actually close with a clip from Sicko. Probably everybody here has seen Sicko at some point, but it's been a while. This is Nye Bevan, who's the architect of the...
Well, if you go back, it all began with democracy. Before we had the vote, all the powers in the hand of rich people. If you had money, you could get health care, education, look after yourself when you were old. And what democracy did was to give the poor the vote, and it moved power from the marketplace to the polling station, from the wallet to the ballot. And what people said was very simple. They said in the 1930s we had mass unemployment, but we don't have unemployment during the war. If you can have full employment by killing Germans, I can't have full employment by building hospitals, building schools, recruiting nurses, recruiting teachers. If you can find money to kill people, you can find money to help people. This is 1948. Your new National Health Service begins on the 5th of July. What is it? How do you get it? It will provide you with all medical, dental, and nursing care. Everyone, rich or poor, man, woman, or child, can use it or any part of it. There are no charges except for a few special items. There is no insurance qualification.
The last 2 minutes, and this is a really good part of it too. We may have to skip Nye Bevan. Well, that's unfortunate, but you can watch this on YouTube at home. One of the ways that the United Kingdom came together after World War II, and we've all seen the pictures after, London after the Blitz, and the destruction in the UK after, really countless nights of German bombing. Their way of coming together was to make sure that everybody had the care that they need. So this was a real sort of moment of solidarity for the British people after World War II, when they created their Medicare for All system. Unfortunately, right now it's under attack by many of the same interests that control our insurance industry. They are trying to introduce more privatization into the UK National Health Service, companies that are also operating in this country are trying to make money in the UK now as well, and undermining the current system. And so, in closing, as a nation, we've never been closer to having a single-payer system in this country. And I do believe in my lifetime that we will have a single-payer system here. And so I would like everybody here to promise me. So who supports Medicare for All now? Probably everybody now that he's left. So if you support Medicare for All, I want you to promise me to take one of the flyers at the back of the room today, take a sign, but call your congressman and tell them to get on HR 1384, which is the platinum standard for a Medicare for All bill in this country. So thank you very much.